Thanks so much. Really appreciate the opportunity to be here to talk to you about, we're talking about immunotherapy versus chemotherapy. And for most of my career, we didn't have a choice. It was kind of just chemotherapy. So we'll kind of go through some of the, through some cases and sort of talk about how we kind of make that call. And unfortunately, it's not a slam dunk that we always use immunotherapy in every patient right off the bat. And so we'll kind of just go through that. So these are my disclosures. And so just we'll sort of review kind of how, as a medical oncologist, how we choose the best treatments, what kind of things how we decide, and then we'll talk about a couple of cases, and briefly, in the context of those cases, review the clinical trial data from Checkmate 743, which established immunotherapy as a standard treatment for mesothelioma. And then there's a new trial that was just presented earlier this year. We'll kind of just discuss how that might influence the treatment landscape. So just basic background, this is probably not news to anybody here, but there are a couple of different subtypes of mesothelioma. And it is fairly important, particularly now in light of what we're going to talk about going forward, that, to really make the distinction between epithelioid and non-epithelioid. And non-epithelioid mesothelioma encompasses two different, so there's like a pure non-epithelioid or sarcomatoid, which is depicted here with these like sort of pointy cells. And then these that are biphasic is kind of a mixture. Those get lumped into non-epithelioid just because the non-epithelioid tend to be the bad actors or the ones that behave poorly. So when we talk about how we make treatment decisions, that does become important, sort of how we classify patients. So just basic oncology principles. When we are sitting in a room with a patient, for the first time, and this is not necessarily specific to mesothelioma, but it is important for patients with mesothelioma as well, is really to establish what is it that we're trying to achieve. So oftentimes in medical oncology, we're thinking along the lines, well, do we think we can cure this patient? Do we think we can't cure this patient? And that really makes a pretty big difference in terms of how we view the treatment options. Because if we can't cure a patient, then we really want to make sure that whatever we're doing is not worse than the actual disease itself. So quality of life becomes something that we talk quite a lot about in patients, with patients. With mesothelioma, as it currently stands, we don't really think that any of our treatments are likely to cure. Now, there are certainly some patients that we can get really good long-term outcomes that sort of feel and act like a cure, but we have to really be very clear with patients that we don't think that the treatment we offer is going to cure, but we can sort of, we can sort of push the boundaries a little bit in some patients, and then some patients we might also think, well, maybe it's better not to really push the boundaries. So we're trying to get a sense from the patient also what they would like to achieve and what we think we can achieve, and try to match those two as best as possible. And of course, when we're thinking about that, we're thinking about what are the risks of treatment, what are the potential benefits, what are the side effects that are going to happen, and then also looking at the individual patient, what are their mitigating factors? So do they have good functional status? Are they otherwise ill from other reasons, other heart disease or other kidney disease that might influence how we might consider treatment? And in the area of immunotherapy, it's very important to know if patients have pre-existing history of autoimmune disease, because that certainly influences the risk. And then we also take into consideration just sort of life circumstances. A lot of patients will tell us that they really want to get to their family's wedding, or their loved ones expecting a baby. They'd really like to be there for that, and so take those things into consideration as we sort of make a treatment plan. So I'm just going to start with a case, and this is a woman that was seen at our center last year. So she's a 70-year-old woman, otherwise pretty healthy. She was a chronic smoker, and so has some obstructive lung disease, which doesn't really affect her too much has occasionally some wheezing when she does a lot of activity, but otherwise really lives pretty normally. Retired, recently retired. She presented with left-sided abdominal pain for about a month. It just wouldn't go away. So initially it was kind of mild, then it was associated with some nausea. She didn't really have a very good appetite and had reported some weight loss. And when we did a scan, we saw that she had this large mass in her left abdomen and a few other nodules scattered about her abdomen. Here is just a representation of the PET scan that was done that shows this large mass here. And this is the CT scan portion of it that shows that mass over there. So that mass was almost 8 centimeters in size. And when she had a biopsy, it showed sarcomatoid or non-epithelioid mesothelioma. So we did have her see a surgeon to see about doing debulking surgery. Because of the sarcomatoid histology, they felt that she was at probably too high of a risk. The extent of the disease was enough that they didn't think that it was really valuable to do surgery in that patient. And so she came to us then to discuss what were our best treatment options. So when we think about the treatment options and we want to sort of ask the question, what are our treatment options? And at the time that we saw her, it was really chemotherapy, which is platinum and pemetrexed chemotherapy, which has been sort of the standard for 21 years, or dual immunotherapy, which is ipilimumab and nivolumab, or Yervoy and Opdivo. So how do we go about thinking about that? So as we were looking, so I just will kind of go over some data and try to keep this relatively high level, but this is the trial that was published back in 2021 that sort of established immunotherapy as the standard of care for mesothelioma. And this is just a schema showing that they randomized a little over 300 patients to receive either a dual immune checkpoint inhibitor, that's nivolumab as an anti-PD-1 antibody, and ipilimumab, which is an anti-CTLA-4 antibody, and we can have a long discussion about what those things mean, but I didn't want to really go into too much about that right now, versus chemotherapy, and this is the standard chemotherapy, platinum or pemetrexed, given once every 3 weeks. And what we were hoping to look at is just to see how did patients do. Their overall survival was the primary outcome, but then also looking at all kinds of secondary outcomes like how did the patient respond, how long do they respond if they did respond, and then how long if they once they started treatment did it take for them to then for it not to work, and then also looking at safety. And I think just noted in the box down there that we excluded patients with autoimmune disease from these studies. So just because of the immunotherapy and the association with autoimmune side effects that we knew about, we didn't want to include patients who had previous autoimmunity, previous organ transplants, and abnormal lung organ function. So all these patients had good heart function, kidney function, et cetera, liver function. So rather than just sort of go through all of the results, I kind of wanted to split it apart. So, half the patients got chemotherapy and half immunotherapy. So I just wanted to kind of go through with you a little bit about what the chemotherapy looked like for these patients, because this is kind of how we think about it in terms of with the individual patients. So the chemotherapy, again, is platinum pemetrexed, or platinum Alimta, which is the standard treatment, as I mentioned. It's given once every 3 weeks. It's all IV chemotherapy, and we give folic acid and B12 shots once every 9 weeks while on treatment to help prevent some of the side effects of the Alimta chemotherapy. And we looked at the outcome so this is from that trial that, the patients who had chemotherapy on average lived about 14 months. But there was a pretty stark difference between epithelioid and non-epithelioid, and this has been pretty much true of all chemotherapy trials in mesothelioma, really throughout history, that epithelioid mesothelioma do quite a bit better than non-epithelioid. And with chemotherapy, the median overall survival is really only 8.8 months, whereas it's about 16.5 months for epithelioid mesothelioma. So once you start treatment, on average, patients would stay on treatment without having their disease worsen for about 7 months. But when we look at the imaging, we see the treatment, about 40% of patients on chemotherapy would actually have shrinkage of their disease. If you do have that shrinkage of the tumor initially to start off with, then about that lasts for about 7 months on average. And you can see here that at 2 years after you've started treatment, only 8% of patients who have achieved a response are still getting that chemotherapy with good response, or still having ongoing response. So in other words, the vast majority of patients will have progressed after about 6 or 7 months. And so what's the cost of this? So this is, and I'm not talking about financial cost, I'm talking really more about the side effects. And so honestly speaking, in medical oncology, platinum pemetrexed is one of our easier chemotherapy regimens. It's better tolerated than almost any other thing we do. But you can see that there are still a fair amount of patients that have significant side effects. So you can see that about a third of patients experience nausea. It's not real severe. It doesn't require them to go in the hospital and things like that, but it does occur at a fairly high rate. About a quarter of patients have significant anemia, decreased appetite in about 20% of patients. The severe toxicity is mostly related to the blood counts. And while those are not, so anemia, if you have severe anemia, that can make people very symptomatic. A low white blood cell count in and of itself is usually not very symptomatic. And actually the rate of infections that happen with the chemotherapy is actually relatively low. But also there are some patients that have pretty severe fatigue and nausea and vomiting with the chemotherapy. And I think one thing about chemotherapy is that, if most patients that get chemotherapy will experience some of these side effects at some time or another, and some of these toxicities get worse over time. So particularly fatigue get worse the longer you're on the chemotherapy. So what about immunotherapy? So this is where the things were, a little bit better. So if we look at the median overall survival, and so the immunotherapy again is nivolumab given every 2 weeks, and ipilimumab given every 6 weeks, and then you continue this treatment up to 2 years of therapy. And the median survival there was 18 months, which was better than the chemotherapy, 14 months. Again, you see, though, that the epithelioid and non-epithelioid seem to do about the same. So the non-epithelioid patients actually get a median overall survival of 18 months. If you remember from a few slides ago, that was the 8.8 months for chemotherapy. And so we see that in the non-epithelioid patients, the immunotherapy is having a pretty big impact on outcomes. I think another thing that is, so the response rate is relatively similar, so 43% for chemo, 40% for immunotherapy. But the duration of response, so if you actually have a response, it lasts longer with immunotherapy. So if you respond, you get a response for about, on average, 11 months. And if you remember, the chemotherapy after 2 years, only 8% of patients are still remaining in response. Here you see with immunotherapy, if you get a response, it usually lasts. So at 2 years, about a third of patients are still having that response to immunotherapy. So it also comes with side effects, and I would say that the side effects now really don't have to do as much with fatigue or with cell counts, but diarrhea is a pretty common one with this particular combination. Still, about 17% have kind of mild diarrhea. 3 to 5% here, so diarrhea and colitis is more severe, clinically significant. Sometimes in these cases have to be hospitalized because of really severe diarrhea. It can cause a skin rash, itchiness, fatigue, but does tend to be mild. The more severe toxicities are relatively uncommon. The unique thing with immunotherapy, of course, is that it works by activating the immune system, and that's great when it works against the cancer, but it also can work against individual patients, and so it can unmask autoimmunity that even wasn't there before. So when you have these immune-related toxicities, it usually responds to steroids. So we give people steroids to counteract it. We usually have to hold the treatment then in that case. If you have an endocrine toxicity, which is autoimmune, so it can affect your thyroid gland, your adrenal gland, pituitary gland, in that case, that effect is almost always permanent. And so in that case, we always have to use replacement hormones. So it's very common to have low thyroid on immunotherapy, and then those patients will have to be on thyroid medication really lifelong. Fortunately, severe autoimmune attack on your organs like the liver, heart, and kidneys are relatively rare in the single digits percentage-wise. But if those things happen, they can be very significant and sometimes life-threatening. And at the end of the day, about 15% of patients have to discontinue treatment because of the toxicity. One very unique thing about immunotherapy, which is kind of interesting, is that even when you stop treatment, oftentimes the effect of it can still last longer. So even in patients if you've had a response to immunotherapy, but then you develop one of these side effects, if we stop treatment, it doesn't necessarily mean that you'll ultimately relapse. Questions so far? Yeah.
Is there a reason that you only do immunotherapy for 2 years? Can you do it longer?
That's a good question. I think you can do it longer, and we have. I think what we have learned is that, just as I said, when you stop treatment, oftentimes it doesn't stop working. And so we've made so a lot of times we think that after you get over to a certain amount of response and you don't see any disease coming back, that there isn't really that much benefit to adding more immunotherapy, and there's only risk, because then you're still exposed to that risk of immune-related toxicity, the immune side effects. Yeah.
Is there a certain number of treatments that you think allow it to continue working, so kind of going forward after you've had a toxicity where you have to stop? And then if you do have to stop, like when do you make a decision potentially to re-challenge somebody to come back on?
Yeah, so that's a great question. I think it's one. I think if a patient has a immune-related toxicity that requires us to stop, there are a few things, like if they're a life-threatening toxicity, we sometimes will say maybe we should not re-challenge. Okay, if it's less than that, but it's still clinically significant, you're in the hospital, felt miserable, then we might say, well, okay, you don't really have any sign of active growing disease. And sometimes when that case, it can be really long-lived, maybe we just keep doing imaging, follow you closely, and we don't re-challenge it until we think that it's clinically necessary.
And the other question about how many treatments you think, like I've had 3 treatments, and I had to stop. I'm just curious.
Yeah, I think when you've had only a few treatments, and then I think we're a little bit more eager to re-challenge, like give you a little bit more time with it, because sometimes it works a little bit better over a longer period of time. But there's not 100% right or wrong answer there either. I mean, I think it's something we have discussion about. Do we feel like we need to go forward if things are stable? But it's an individual kind of decision, really. Yeah.
If you can't tolerate both of the drugs, do you sometimes re-challenge?
Absolutely. Yeah, absolutely.
Success rate of that?
Yep, absolutely. So, the ipilimumab is the CTLA-4 medicine, and that seems to be much more associated with the immune-related toxicity. And so in a case where somebody has like severe colitis or diarrhea, then we'll sometimes resume, but only with the Nivo. I don't think there's a lot of data in mesothelioma about how well that works in that case, but in melanoma, it's very common, and most patients will continue to receive benefit from the nivolumab. So this is just putting the two things side by side, the chemotherapy and the immunotherapy on the right-hand side. And you can see that overall, when we look at the whole patient population, the survival is better. When you look at epithelioid, it's really not that much better. It's very minimally better. And in fact, if you look at the statistics on this trial, it actually isn't statistically significant. in epithelioid patients. In the non-epithelioid patients, it's way better. And so I think it's pretty clear if you have non-epithelioid mesothelioma that we're going to probably talk about doing immunotherapy as our number one option. I think, again, pointed out before, but the duration of response really favors immunotherapy. So sometimes we think about it in the context of a patient. What is your goal? And, if the goal is, sometimes they're not that symptomatic to begin with, and they're looking really long-term, like, this is probably going to be something that may last longer. We'll take a chance by starting the immunotherapy first and saving chemotherapy for later. In somebody who's more symptomatic, they need a response right away in epithelioid histology, then we sometimes think about doing the chemotherapy first. So in our patient, she had a sarcomatoid histology, and we chose to do immunotherapy with ipilimumab and nivolumab. As I mentioned, clearly show that it's better than chemotherapy with this histology. She actually had a really great response. So within about 2 months of therapy, her pain was gone. The tumor, I'm not sure how good this projects, but you can see on the left-hand side, this is where we started. And after 4 months on Ipi and Nivo, she had a pretty significant shrinkage of the tumor. It's about a third of the size that when we started. So she did really well for about a year. She only side effect was low thyroid function, and that was something we detected on labs. Wasn't symptomatic. We put her on hormone replacement, and she did fine with that. However, about a year into her treatment, she developed immune-related colitis, so she had pretty severe diarrhea. I think she was didn't have to go into the hospital, but was having like 10 stools a day, so pretty miserable. We gave her steroids, got better. She required interruption of the immunotherapy, and then with discussion with the patient, she really felt bad enough with the diarrhea that she wasn't really, and she had no evidence of disease on her scans. So she elected to hold off on any therapy, and she's now been off of therapy for 9 months without any relapse of disease. So in many ways, even though she had this colitis, this was kind of a win for immunotherapy in that it really has kept her disease under control for a long period of time. And for that whole year prior to developing the colitis, she had almost no side effects from the immunotherapy at all. So I'll move on to the next case, which is a slightly different scenario. So this is a 71-year-old man who presented to us with worsening shortness of breath. He had a history of high blood pressure, but otherwise pretty healthy guy, normally pretty active. He really loved to play pickleball, so he played pickleball like 4 days a week. And he didn't really have a lot of symptoms other than the shortness of breath, didn't have any chest pain. No weight loss. Really wanted to get back to playing pickleball, and having to get this fluid drained was really kind of a drag on him. So when he had fluid in his lungs, he really couldn't play and couldn't do those things. But when he got the fluid drained, it actually helped. So he was able to kind of go back and do what the things that he wanted. So at the time, he had a thoracentesis, which is to take the fluid off. He had a biopsy of the pleural nodule that showed an epithelioid mesothelioma. On a PET scan, he did have some lymph nodes enlarged, and if we go back here, you can see this area here in the mediastinum, sort of between the lungs, a lymph node that had lit up. I don't think you can see it over here, but there is also a lymph node in the supraclavicular area, like outside of the chest, that lit up as well. So at that time, he was really wanting to be aggressive with his mesothelioma, was really gung-ho about trying to get surgery. We had talked about the pros and cons of doing a pleurectomy decortication. But the surgeon saw that he had these lymph nodes that were positive and said, well, I think you're in pretty good shape. I think we could do surgery, but I would really like to see, how you'll respond to some treatment, because if you don't respond well, you've got this disease that's outside the lung. The time it takes you to heal up from surgery, things might get out of control. So she sent him over to me to say, let's think about doing some treatment first. So what are we going to choose? I think just the way I've framed this talk, you could probably guess, but we actually chose chemotherapy. So again, he had pure epithelioid histology, not that much worse than immunotherapy in terms of the outcome, really about the same. But he really wanted to get to surgery, and so we thought that that gave us the best chance of an early response to treatment. And so we gave him chemotherapy. We could still use immunotherapy later if we wanted to. And we had a lot of discussion about it, the pros and cons of each approach, because yes, from the data that I've showed you, you could choose the other way. But we just sort of thought that because of the epithelioid histology that he'd have a better chance of responding to chemotherapy up front. And so we thought we'd go with that. And he actually did have a really good response to chemotherapy. He tolerated it extremely well, was able to receive all his treatment on time. A little bit of fatigue, but he still continued playing pickleball all throughout the whole time that he was doing it. And he did ultimately then get to so you can see here that his pleural thickening here on the left side of the tumor had gone away, and the lymph nodes also melted away with the chemotherapy. So he ultimately did have a pleurectomy. I think one thing that was interesting, that when we did the pathology after the surgery, they did show biphasic mesothelioma, which is again like a mixed histology, epithelial and non-epithelioid. And this does raise an issue in terms of when we get biopsies, we're getting a little tiny piece of tissue, and sometimes it could miss that there's other parts of it that have the non-epithelioid. So I think had we known biphasic from the beginning, we might have changed our thought process a little bit. So we talked after surgery, again, because of this, should we start immunotherapy now? And we kind of, again, weighed the pros and cons of it. He really was like, well, I just gone through this big surgery. I'm recovering. Again, just want to get myself back on my feet. And so he decided he didn't want to start any active treatment at that time. And so he's actually now 6 months or so after his surgery. His most recent scans didn't show any evidence of any relapse. And then we would probably recommend immunotherapy then if he did ultimately relapse. But he's doing well for now. So just with a few minutes, I think probably over time already, but just with the few minutes I have here, I just want to mention the most recent study that was presented this year at ASCO. This was a trial that was done in Canada and Europe, where they used. So you can imagine that we have some questions about how effective immunotherapy is. We have some questions about chemotherapy, but what about if you do both? And this is really standard treatment for lung cancer now, to do chemotherapy with immunotherapy. The difference here is that with the immunotherapy is pembrolizumab or Keytruda, and it's done by itself, not with a second immunotherapy. So chemotherapy plus pembrolizumab versus just chemotherapy by itself. And the upshot of it is that chemotherapy plus immunotherapy was a little bit better, not by a lot, maybe a little bit disappointing that it was only slightly better. So the overall survival was 17 months in the chemotherapy plus immunotherapy arm versus 16 for the chemotherapy arm. The response rate was pretty astounding, 61% with the combination, which I don't think we've seen that in any clinical trials of mesothelioma to date, and was certainly better than just the chemotherapy by itself. But again, you see this problem, this difference between the non-epithelioid and epithelioid. So again, the non-epithelioid patients did quite a bit better when you got chemotherapy plus immunotherapy compared to just the chemotherapy alone. In the epithelioid mesothelioma, the chemotherapy plus immunotherapy was a little bit better, but really not by very much. And in this trial, the epithelioid patients actually did a little bit better with the chemotherapy than they did in the previous trial. One thing that was good, there was no surprising toxicity, but not too surprising that when you combine chemotherapy and immunotherapy, you get the chemotherapy side effects and also some of the immunotherapy side effects. The immunotherapy side effects are a little bit easier with this regimen, and that's because we're not including the ipilimumab, which accounts for a fair bit of the immune-related toxicity. So this was just FDA approved in September. So it's in our one of our treatment options now that we can give to patients. This is just another table, just sort of looking at the three different sort of options: chemotherapy, immunotherapy, and the combination. And you can see again that both with immunotherapy, we see a little bit better results with the non-epithelioid patients compared to chemotherapy, whereas with the epithelioid, they kind of look relatively similar whether you get immunotherapy or not. So in conclusion, I guess we have 3 FDA-approved options for first-line treatment of mesothelioma. I think for non-epithelioid, I've hopefully convinced you all that there isn't really much of a choice. We just do immunotherapy, and that's probably our best option. We don't really know if there are cases that would benefit from chemotherapy, but from the looks of the data, it really doesn't seem that way. So I don't think either chemotherapy plus immunotherapy or the chemotherapy arms are really very good for non-epithelioid. For epithelioid, it's still a little bit of a question mark to me. The efficacy is about the same. There are some patients clearly benefit from immunotherapy. We just have a hard time picking them out. But if you do benefit, it lasts for a really long time. And so it really would be nice for us to be able to pick out the patients who are really going to benefit. And then, whether or not to put the immunotherapy first before chemotherapy is sort of a question mark. And I think this is a thing what we do in oncology is sort of really talk about shared decision making, sitting down with the patient, discussing the data, and discussing the goals, and make a nuanced decision for each individual patient. And I guess in that way, it's really nice to have options. So we have 3 different options, and we can kind of talk through sort of what are the risks and benefits of each approach, and really have a good discussion about what we hope to achieve with either one. So obviously, there's a lot more work to be done. I think we want to identify biomarkers that are more predictive than just the histology. So incorporating genomics where we can, expression patterns. I think a really important question for all of oncology in general is which patients need the ipilimumab, because I think we could avoid a lot of immune-related toxicity if we could avoid the ipilimumab. But there are clearly some patients who don't respond to Keytruda or nivolumab and need the ipilimumab, but we have no clue who those patients are, and that's true of all cancers: lung cancer, melanoma, kidney cancer, what have you. And then I think obviously we want to identify better treatments, better immunotherapies. I myself have been involved in looking at VISTA and B7H3 in terms of new targets for mesothelioma, developing newer treatments, better targeted therapy. So with that, I'll finish. If there are other questions, I can take them now, if we've got time.
I don't see any hands going up. Oh, there's one.
Should I wait?
No, we can take one question. We really need to get ourselves back on track here.
I'll defer to a patient.
Okay, go ahead.
Is there any reason to think that immunotherapy could be used in the heated intraperitoneal context like chemotherapy was?
Well, I think it's. I'm not exactly sure what the rationale would be. Maybe for the the inflammatory kind of thing. I think it could be. I think it obviously would have to be something that would be done in the context of a clinical trial. And there are other strategies that are involved using immunotherapy prior to doing a pleurectomy decortication. There's studies that are ongoing looking at those kind of things as well.
Wonderful. A hand for Dr. Patel.
Thanks so much.